Hello everyone, I'm Pulkit Khandelwal, a PhD student in the Department of Bioengineering at the University of Pennsylvania, where I'm advised by Professor Paul Yushkevich. Today I'm going to talk about our work on domain generalization in medical imaging using Metalearning. You can reach out to me via my email and can also find the code at the given GitHub link. This work was supported by an NIH grant. Here is the outline of the talk. We start with a brief introduction and provide the key motivation for the problem, followed by the description of the algorithm and the related implementation details. We will then present the results and provide a discussion. Finally, we will end with the conclusion. Deep learning models perform best when tested on test data domains whose distribution is similar to the set of training domains. However, model generalization can be hindered when there is a significant difference in the underlying statistics between the target and source domains, known as covariance shift. Several factors such as differences in imaging modalities, patients' imaging acquisition protocols, medical centers, healthy and diseased populations, and age contribute to a deep model's lack of generalizability. Addressing covariance shift by retraining deep models on each new data domain is impractical in most applications because of the scarcity of expert-labeled data, and therefore it is important to develop methods that generalize well to new related datasets not seen during training using few or no annotated examples from the new dataset. Domain adaptation and generalization are two such paradigms which aim at reducing this covariance shift. Domain adaptation learns a feature representation that is both invariant to the statistics of the source and target domains and is discriminative enough for the actual learning task. Domain adaptation uses some examples from the target domain and could be either unsupervised or supervised. There has been several prior work in domain adaptation for biomedical imaging across several settings. We briefly highlight some of the key methods. Adaptation across different medical centers for image segmentation through both unsupervised and supervised methods have been proposed. Cross-modality adaptation between MR and CT images have been proposed using variational autoencoders for whole heart segmentation and using cycle GANs for segmentation of the prostate. Decision forests have been employed to adapt between in vivo and in vitro images for intravascular ultrasound tissue segmentation. Few-shot learning is a training scheme which adapts a trained model to a completely new data distribution with very limited training examples and has been used to segment multiple organs in MR images. Domain generalization trains models using a variety of source domains to learn a generic feature representation which should perform well on unseen target domains, and does not use any training examples from the target dataset. To the best of our knowledge, domain generalization is a relatively lesser studied topic within biomedical context, especially for image segmentation. We now discuss some of the previous work and highlight their drawbacks. A stack of 9 data augmentation techniques were applied to the training domains to mimic the test set for segmentation. The method is not tested on disease populations, which could vary significantly in anatomies and shapes from a generic healthy population. The model has been trained on a large training data, which might not be the general case for many problems in medical imaging, where the goal is to extract enough information from very limited data for domain generalization. An episodic training-based meta-learning method was applied to segment brain tissue in T1-weighted MRI across 4 medical centers. This method contains similar anatomies in both the train and test sets and therefore might suffer from generalizability to cases with atrophied or irregular brain anatomies. A variational autoencoder was used to learn 3 latent subspaces to generalize across patients for 2D cell segmentation tasks via domain disentanglement. The method evaluates only on 2D dataset, not extending to the 3D case. In the current Miccai conference, a shape-aware meta-learning approach to generalize across prostate segmentation has been proposed. This work is similar to ours given that the base algorithm is motivated by the same meta-learning algorithm. Here, different medical sites mimic the distribution shift in the domain distributions, which might limit the generalizability to different settings. In the present work, we extend the gradient-based meta-learning domain generalization method that has shown promise for image classification tasks to the context of biomedical image segmentation and call it MLDG-SEG. To evaluate this approach, we focus on the problem of vertebrae segmentation in CT images and utilize 3 publicly available databases. We would like to mention that domain generalization should not be limited to the context of difference in medical centers and sites only. Therefore, to address the drawbacks of existing domain generation methods as mentioned in the previous slide, we construct 3 domain generation contexts. First, generalization to new anatomies. Second, generalization to disease population with fractured vertebrae, dislocated discs. And third, generalization to unseen anatomy, surgical implants, different acquisition protocols, arbitrary orientations, and field of view. Through these three contexts, we will show that MLDG SEG is able to learn generalized representations from very limited training examples. Finally, we show that the learned generalized representation can be quickly adapted with a few examples from the unseen target distribution in a case-short learning setting to achieve additional performance gains. Metalearning is a class of algorithms which aims at learning a variety of tasks and then quickly adapting to new tasks in different settings. We adopt the optimization-based model agnostic method proposed by Lee et al. Called Metalearning domain generalization. Let's consider a motivating example from an image manifold of lumbar, lower thoracic, and middle thoracic regions which comprise the set of source domains S, as well as the upper thoracic region which constitutes the unseen test domain called T. Both S and T share the same task, for example segmentation or classification with the same label space. The goal of MLDG is to learn a single set of model parameters theta via gradient descent and two meta-learners, meta-train and meta-test procedures. The model is trained on only the source S domains and then tested on target T domain. The source domains S are split into two sets, meta-train domains and meta-test set domains. The goal of the two splits is to mimic the setting of domain shifts and thereby make it easier for the model to generalize on an unseen target domain. Here we briefly describe the algorithm. Consider a set of source domains S. The MDG method is supposed to learn a single set of model parameter theta with the help of two optimization steps. There are three hyperparameters alpha, beta, and gamma. At every iteration, the set of images in the source domains, here D1, D2, and D3, are randomly split into a meta-train, for example, consisting of images from D1 and D2 set, and meta-test with the set D3. Now two losses are computed. The first loss F is computed using the training examples from meta-train set, and the gradient is computed with respect to the model parameter theta. The second loss G is computed on the meta-test set with the updated parameter theta prime. The key idea by introducing the second loss in the meta-test stage is that an improvement of the model's performance on the meta-train set should also improve the model's performance on the meta-test set. The final model parameter theta is updated by taking the gradient of the weighted combination of the two losses F and G. By doing so, the model is tuned in such a way that performance is improved in both meta-train and meta-test domains. In other words, the model is regularized and does not overfit to one particular domain by finding the best possible gradient direction due to the joint optimization of the two losses. Now compare this to a vanilla setup where a model is directly given images from the three domains D1, D2, and D3 without any meta-learning setup. This model might overfit to a domain by minimizing its loss and maximizing the loss for other domains. Next, we highlight the three experiments which forms the key contribution of the current work. In experiment 1, the aim is to let the model generalize across the underlying vertebral anatomy, the intensity profile, and the surrounding intervertebral disc space, which varies significantly along the vertebral column. For this experiment, we used the CSI challenge dataset consisting of 10 healthy adult cases with manual segmentations provided for thoracic and lumbar vertebrae. The images in all the subjects of the CSI database are divided into different regions: lumbar L1 to L5, lower thoracic T9 to T12, middle thoracic T5 to T8, and upper thoracic vertebrae T1 to T4. Each of these regions comprise of a domain. In experiment 2, the model generalizes from healthy subjects to the structure of fractured or dislocated vertebrae images obtained at a different medical center. Here, the XWORD SEG challenge dataset consisting of 15 pathology cases with both fractured and non-fractured vertebrae are used. Manually labeled lumbar vertebrae segmentations are provided. The four domains, that is lumbar, lower, middle, and upper thoracic regions from CSI healthy database comprise the set of source domains. The XWORD dataset with pathology cases comprise the unseen target domain. In experiment 3, the model generalizes to unseen anatomies, different acquisition protocols, arbitrary orientations, field of views, and pathology. Here we use the worst Miccai segmentation challenge dataset, which has labeled lumbar, thoracic, and cervical vertebrae. The model is trained on CSI and expert seg database from experiment 1 and 2 and then tested on worst dataset. We now describe the 4 procedures implemented for each of the 3 experiments. Since the MLDG method is model agnostic, we design a custom 3D unit-like architecture in the present work. Baseline is the vanilla unit-like architecture. The model is trained on the source domains and then tested on the unseen held-out test domain. MLDG seg is the vanilla 3D unit-like architecture trained under the algorithm as described earlier. Once the MLDG seg model has been trained on source domains, it can be quickly adapted via fine-tuning using very limited label examples from the unseen target domain. The weights of the encoder and bottleneck layers of the 3D unit-like architecture were frozen in the K-short learning experiments for fine-tuning. To establish a theoretical upper bound on segmentation accuracy, we train the vanilla architecture using labeled examples from the target domain and then test on held-out examples from the target domain. This is presumably the easiest task since the training and test domain distribution are similar. However, in our relatively small datasets, the amount of available data for the Oracle experiment is smaller than for the domain generalization experiments. So, Oracle performance reported in the paper should be read with caution. The key implementation details are as follows. All the images are converted to 1 cubic millimeter isotopic resolution. The images are standardized using mean subtraction and division by standard deviation and then normalized between 0 and 1. The optimization used was stochastic gradient descent. Dropout with 0.3 probability was used and the normalization technique employed was group norm. The loss function used was generalized dice coefficient loss. The 3 hyperparameters alpha, beta, and gamma are set to 1. In experiment 1, we use 10 epochs and experiments 2 and 3 were trained for 15 epochs each. We randomly sampled 50 patches of size 64 by 64 by 64 from each subject image. From these 50 patches, we rotate and flip 30 randomly sampled patches. For K-short learning experiments, 5 patches were randomly selected from each of the K subjects. For the purpose of method evaluation, we compute dice coefficient, a volume-based measurement, and the average symmetric surface distance in mm, a surface-based metric between the ground truth image and a given model procedure segmentation output. We perform pairwise Wilcoxon sign rank tests between the baseline and each of the other procedures in all the 3 experiments for both dice code and ASSD. We now present and discuss the results for the 3 experiments. The aim in experiment 1 is to generalize across the underlying vertebral anatomy, the intensity profile, and the surrounding intervertebral disc space, which varies significantly along the vertebral column. Here the source and target comes from the CSI dataset. Lumbar, lower thoracic, middle thoracic, and upper thoracic vertebral regions comprise of a domain. See the figure on the right for a qualitative result. MLDG seg is better able to segment the region of interest by having significantly reduced background error than the baseline. In addition to the correct delineation of intervertebral discs, when the held-out distribution shown here is the middle thoracic region. A further improvement in performance is obtained using additional K-short examples over MLDG seg. Here K is equal to 2. This supplementary figure shows the results for lumbar, lower thoracic, and upper thoracic regions as the held-out set. Again, the results confirm the superior performance of MLDG seg and K-short learning. We now describe the results quantitatively. Each row reports the result for the held-out set when the model is trained on the remaining 3 domains except the oracle, which is trained and tested on the same domain. Each row reports dice score and AAST within brackets. MLDG seg consistently outperforms the baseline. With a very few labeled examples from the test distribution, we see a further boost in performance. Ideally, the oracle should have the best performance than the rest of the procedures as the test domain distribution is similar to the training domain distribution. Here in this particular experimental setup, it is not surprising that the MLDG method performs better than the oracle. This might be due to the limited number of training and validation examples available to train the oracle in this particular experiment. Furthermore, since all the procedures we trained for a fixed number of epochs, the oracle might have had a disadvantage of being trained for a lesser number of gradient steps than the MLDG sec procedure. An alternative approach would be to train a single oracle model which learns from all the domains simultaneously and then test on each domain separately. In experiment 2, the 4 domains lumbar, lower, middle and upper thoracic vertebrae from the CSI healthy database comprise the set of source domains. The expert database with pathology cases comprise the unseen target domain. Here the aim is to let the model generalize from the vertebrae of healthy subjects to the structure of fractured or dislocated vertebrae images obtained at a different medical center. The figure shows that MLDG sec is better able to delineate the vertebrae by not segmenting the undesired spinal cord as incorrectly segmented by the baseline. The K-shard method, where K is 2, provides better segmentation than the MLDG sec method. Quantitatively, again the Metalearning method outperforms the baseline with further performance improvements with K-shard learning. Here again it is not necessarily surprising to see that MLDG sec performs better than the oracle. The oracle was trained with a smaller number of subjects than the baseline and MLDG sec. In experiment 3, the source domains consist of CSI and expert datasets and the target consists of the versatile VERSE dataset. Here the aim is to generalize to unseen anatomies, different acquisition protocols, arbitrary orientations, field of views and pathology. The figure depicts the superior performance of MLDG sec over the baseline on a compression fraction subject from a different distribution than the training set, where MLDG sec is able to segment more vertebrae completely than the baseline. The K-shard setting further improves the performance by segmenting the remaining vertebrae not segmented by baseline or MLDG sec. In the table, we see the improved performance of MLDG sec over the baseline and consistent performance boost in the few-shard learning regime. The K-shard procedure is either on par with the oracle or outperforms the same for K equals 4, 5 and 6. Here the oracle performs better than most of the procedures, which is due to the fact that the training set for oracle is relatively larger than in experiments 1 and 2. Finally, shown is a spaghetti plot for experiment 3. Y-axis shows the dice coefficient for the different procedures, which are shown on the x-axis. Each of the plotted lines denote an individual test subject. It can be seen that MLDG sec method performs better than the baseline method, and further performance improvement is achieved by the K-shard method. Shown in the figure is a Disney plot for the 2 trained models. The bottleneck layers features are plotted when the upper thoracic region was held outside in experiment 1. The 4 colors represent the 4 domains, namely lumbar and the 3 thoracic regions, lower, middle and upper. It can be seen that the domains are more separated out in the trained baseline model, whereas the MLDG sec method learns domain agnostic features and better generalize the model. Lastly, to conclude, in this work, we benchmark MLDG sec across a variety of training and test settings such as multiple medical sites, unseen complex vertebrae anatomies, surrounding intervertebral disc space, varying bone and soft tissue intensities distribution, disease populations, different acquisition protocols, arbitrary orientations, and field of views. As mentioned and discussed previously, a limitation of the present work is the poor performance of the oracle. We would investigate this in a future study. Some extensions to the work will be to evaluate the method on other modalities and compare with the recently proposed domain generalization methods in biomedical imaging. With this, I would like to invite you to read our paper and check out the supplementary material for additional details and results. Thank you for paying attention, and I'm happy to chat more about our work via email.